Shoulder by design is allowing us a lot of mobility. In fact, shoulder is the most mobile joint of all the joints in the body. It comes with a trade-off, and that's decreased stability. Therefore, shoulder dislocations, shoulder injuries, shoulder and rotator cuff pathologies are so common in humans, especially athletic population or aging population. In this video, I will show you drills to improve stability of the shoulder. This will be very much about stabilization from the deep muscles of the rotator cuff of the shoulder. On this channel, my mission is to help you guys or guide you a little bit in your prehab at home rehab. Knowledge is power. So by knowing more about what you're dealing with, how the joint is structured, how it's supposed to function, what can also help yourself. As you can see in the image, we've got a scapula. Scapula and humerus, which is our upper arm bone, form a glenohumeral joint, which is a glenoid. That's the fossa of the scapula, and the humerus, which has got huge head, right? And that huge head sits in this small glenoid fossa that it's only really increased by the labrum, which is the cartilaginous ring around the glenoid, to increase congruency of the joint and also to increase its stability. For stability, guys, we obviously depend on passive structures like bones, like the socket itself, like a joint capsule and ligaments that blend into the capsule, but also on the dynamic stabilization of the muscles that surround the shoulder. We don't only depend on the rotator cuff, but also on all the periscapular muscles that I've covered so extensively in my last video.
All right, guys, so let's take a look at the anatomy of the shoulder. This is a perfect model for us to appreciate the complexity of the shoulder complex. Here, I'm pointing to you on the deltoid muscle, right? So the most superficial muscle that gives our shoulder that round shape, the curvature, the roundness of the shoulder, right? Beautiful muscle. If I were to hide this particular muscle, this shows the amount of ligamentous, muscular structures, accessory structures like bursae in this area. You see all the ligaments that I mentioned. This reinforces this whole structure. I'm pointing here out the subscapularis. And if I were to fade all the other muscles, you see how deeply positioned that muscle is. In fact, all this is covered, right? So this muscle is really hard to get to and is a real big troublemaker. It's also the strongest rotator cuff of the shoulder. Lesser tubercle, this is where the subscapularis attaches, and this is the greater tubercle of the humerus. We've got attachments of the infraspinatus and teres minor. Now, when you look at this muscle here, which is again just above infraspinatus, this is the spine of the scapula over here where my mouse is, and this is our supraspinatus. And that attaches again here to the greater tubercle. Superiorly above the subacromial space, you can see bursa under the acromion. And this is again the area that frequently get squashed and is also prone to some sort of degenerative changes and injuries because of the lower blood supply to that insertion of the supraspinatus. I talked about subacromial space and potential problems with bursitis when there's a lot of compression in this area, or sort of poor function of the shoulder, poor function of the shoulder complex, and a lot of repetitive overhead activities, how these structures here may be compromised. Also, you can appreciate the different ligaments. That's passive support of the shoulder joint versus all the muscles, all the red stuff that you see are the active or dynamic stabilizers of the shoulder. It really comes from these four sits muscles, so-called sits.
So a good way to determine whether you've got a problem with your subscapularis would be simply pressing into your belly, or maybe reaching behind you, trying to lift the hand off your back. And if that is problematic, we're potentially looking at a problem with subscapularis, versus a movement into abduction with potentially thumb pointing down. You may be looking at subacromial impingement, which maybe indicates that we've got a problem with supraspinatus. Okay, now when it comes to external rotation movement here, if that is painful against resistance, like pulling the band this way or pulling that way, if you find that this is painful, we're potentially having a problem with infraspinatus. The rotator cuff pathologies encompass tears, tendinitis, tendinopathy in more chronic stages, weakness. And we can see that pathology increases with overuse, with age. Again, women post-menopause are more prone to tendinopathies and problems with tendons in general due to the lower level of estrogen. Frequently manifests itself with pain, kind of discomfort around the deltoid area, and loss of active range of motion of the shoulder, kind of night pain, sleeping on that shoulder. Those are just a few of presenting symptoms. Okay, some studies also list that poor posture has been a predictor of rotator cuff disease, even though that the tears of rotator cuff tears were present in over 65% of patients with kyphotic lordotic posture, so that sort of position of the spine. And yes, really there's no one bad posture or there's no one fantastic posture, right? The bad posture is the one that is too excessive and held for a very long time, and the one you cannot get out of. By simply moving and making sure we're not spending hours upon hours in the same position, either slouched or in any position really, we are definitely helping ourselves. So I think, guys, it's worth watching out for that slouched position anyway. Doesn't necessarily mean you're going to get a shoulder problem. However, there's a lot of things that are compromised when we hear. And then the weight of the head with every degree of going forwards, it's putting our strain on our necks and our thoracic spine, but also it's the structures in the shoulders, it's the muscles along the posterior chain, it's our fluid dynamics, right? Because remember, that area, if it's compressed, that's where the vascular structures go, that's where our lymphatic system is. And also, when we're in this position, again, our respiratory function will be also limited. Among other risk factors for rotator cuff problems, it's also trauma, right? Like bike accidents and falls and so on. Micro trauma causes tendon degeneration, and with insufficient healing, it leads to degenerative tears. But it's just, the pathology of a tendon is a change in the structure of tendon, a change of quality of the tendon. And unfortunately, nothing is as good as it first created, right? So any injury will unfortunately alter the state and quality of the tissues, whether we want it or not. Any fall on the outstretched hand, on the elbow, on the shoulder, any injuries where our neck is involved, these structures, the whole really shoulder complex would be affected. In osteopathy, we look at everything. We look at the scapula, we look at the glenohumeral joint, the shoulder itself, and the rotator cuff muscles, but we're also looking at the collarbone, and we're looking at the first rib, and also frequently we're looking at the cervical spine, the C-spine, the neck, because through ligaments, through muscles, through fascia, through myofascial chains, everything here is so linked. And also the nerve supply that goes from the neck, right, through the brachial plexus, underneath here the scalene muscles, underneath the pec minor, and then spreading to the arm all the way to the fingertips, supplying sensation and also supplying the muscles, right, allowing us to move, allowing us to feel. And guys, just a word of advice from someone who exposed to these clinical encounters and hears a lot about those pains, and also a person who firsthand experience shoulder issues. Don't wait, okay? Don't let acute problem become a chronic problem, because we want to really tackle and reduce the risk of decreased function in the shoulder as soon as possible. Okay, stick to your rehab if you've been given one. Lots of people get a rehab program, they do it a little bit, the pain subsides, and then they completely abandon the whole idea of rehabbing. Remember that the working on something that's already been damaged once, it's a lifelong process, in my opinion. We don't want one injury affect and spread and affect other parts of the body. And unfortunately, with the shoulder pain, it can affect the way you carry yourself. Maybe you're avoiding certain movements. There may be atrophy of other tissues. Ultimately, we're kind of limiting ourselves. We're adapting to the injury, right? But we want to really adapt the injury to our life. We want to work on the injury and restore function. A lot of the things I'm about to show you are used as a rehabilitation. With conservative approach, you can gain a lot.
All right, guys, here are the few things that worked for me with my shoulder rehab and what I continue doing as a warm-up, as a maintenance, as an accessory work. First one, it's a all-fours quadruple position. And we're going to work with very light resistance band. Okay, you can use a loop or you can use a regular band and just create a loop. Now check out the positioning of the arms. Yeah, inner elbows turned inwards just to make sure the shoulder works a little bit harder.
And you simply performing a little abduction movement to the side. And you move slightly downwards, you move upwards. So we're trying different vectors. And it's not just about the arm that's moving, but it's also about the arm that you're pushing down with, that you're stabilizing yourself with. Okay. Also forces you to really sort of brace and keep your midsection nice and strong. Maintain straight elbows. Keep those movements slow and controlled. And here is a wall-based variation. You're doing exactly the same thing, but here now you're pushing into the wall instead of pushing into the ground. And if you've got access to reformer, this is what I've been doing on one yellow spring. Second drill, and probably one of the most important ones. And the main idea here is to maintain engagement of the rotator cuff, specifically external rotators, infraspinatus, teres minor, as you're going overhead, right? So here I'm really trying to stretch the band with my hands while keeping my elbows in line with shoulders. Don't let those elbows wing out to the sides, right? Keep fighting as you're going overhead to maintain that stretch on the band. My third suggestion going to be a side lying drill with dumbbells or plates. So here I'm starting you off with infraspinatus, external rotation of the shoulder. Amazing drill as a rehab, but also as a maintenance. If you're rehabbing, light weights, half kilo. If you're maintaining, obviously you can go a little bit heavier. I'm using here close to 2 kilograms, and I'm just doing, again, like you see, axial rotation of my glenohumeral joint. Now, progressing into stabilization, I like to use in this exact position with my lower arm pushing into the ground, while top hand is just doing kind of forward reaching. So by the time you get to that top arm being straight, hold, because that's obviously where we get the most work in the shoulder, the most stabilization challenge. I'm just gliding that arm in horizontal plane parallel to the ground. A little top up or a third variation of this movement would be to go straight into horizontal abduction. And again, moving slowly. I'm decelerating as I'm getting closer to the ground. It gets much easier as you actually reaching to ceiling. So slow down as you're getting closer to the floor. And yes, ideally use the props I'm using, like support your head, support your rib. It will keep your spine in a good alignment. Okay, number 4, what we call draw a sword or backhand in reformer Pilates. So this is just exercise from reformer done at home. You need a band, light, medium. Attach the band. Do something. I'm attaching it to my sofa. And you start with palm facing your belly. Lead with the elbow, lead with the shoulder, and then rotate from the shoulder to actually go into abduction, like reaching sideways as if you were pulling a sword out of the sheath. Okay, so control. It's again good stabilization exercise, and also nicely works, especially external rotation through the shoulder, pretty much whole cuff. And this is the actual drill that you can do on the reformer if you get access to one, and that is done on a yellow spring or blue for progression. And final drill, it's a simple side plank with rotation. So it's like a threading the needle. Level 1 with knees together, with knees on the ground. And again, the main idea is that you're pushing down through the forearm, you're not letting your rib cage sink, right? So you're losing the stability from the shoulder. Keep pushing down with the elbow and forearm, keep lifting those hips. Exterior view. Notice I'm twisting my mid-back, my mid-thoracic spine, not just moving the arm or head. And progression with straight legs. Much harder for the obliques. Yeah, you can use that to work your core as well. Thanks for tuning in. I hope you found this beneficial. Look after yourselves, look after your shoulder, and I will see you soon.